Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program on Power 96.5 FM, WUFO 1080 AM. I'm your host for today, Francesca Messiah, Kaleida Health Manager, Workforce Development. Who is Kaleida Health? Kaleida Health, we are over 13,000 strong patients, we're over 13,000 strong employees. Kaleida Health, our flagship hospital, Buffalo General Medical Center. And then we have our Oshai Children's Hospital, Millard Fillmore Suburban, Gates Vascular Institute, the Visiting Nursing Association that provides home care for all ages, 7 days a week within the 8 counties of Western New York. We also have part of Kaleida System is High Point at Michigan, skilled nursing facility, rehab facility, and more. We have DeGraff Medical Park, as well as DeGraff Skilled Nursing Facility. And both of the DeGraffs are located in Niagara County. We have a cancer division. We have clinics through north of the city, south of the city of Buffalo that have all kinds of services from cardiac to rehabilitation, physical rehabilitation. We have OBGYN clinics. We have all types of, clinics for adults. We have labs. So as you can tell, Kaleida is large, and that's why we are Western New York's largest healthcare system. And our topic for today, I believe, is a relatively new topic or new department within Kaleida Health. And our topic for today is care management and post-acute care transitions. And our guest for today is one of my colleagues who's relatively new with Kaleida. I don't think you've been here a year, Andrea Wallace Stewart. Good morning, Andrea. How are you?
Good morning. Thank you so much for having me.
You're welcome. And how long have you been with Kaleida Health?
I've been with Kaleida since August 2024, so about 7 months.
About 7 months. So welcome to Western New York.
Thank you. I love it. It is so beautiful, and the people here are just so welcoming. I'm so blessed to be here. Thank you.
Oh, great. I'm glad. Well, first of all, and Andrea, I want to introduce who she is within Kaleida and what hat she wears. She is the vice president of care management and post acute care transitions. Did I get it right?
Yes, Vice President of Care Management and Post-Acute Care Transitions for the entire health system, Kaleida Health System.
And so on that note, if you could please describe what is care management and post-acute care transitions? And it's like a two-part question. And how does this affect patients and their families at Kaleida Health?
Great question. So, even though it's a really big title, it's two parts. So, care management really deals with making sure that the patient's care is coordinated and adequate, not only throughout their hospitalization, but it's also once they're discharged, making sure that they are transitioned from the hospital into the most appropriate level of care in the community to ensure that they're getting the services that they need, that they're healthy, that they're whole. And it's not just the patient, and it also includes the family, because the family is the best support for the patient. So it's care management in the hospital, but also when it comes to post-acute care transitions, once the patient is being discharged back into the community, making sure that they have the services they need, they're in the most appropriate level of care, whether it's home with home care, whether it's at another facility that best meets their needs to ensure that they have the best outcomes.
So, okay, and I've okay, then going from there. So does care management work with the discharge department? Because I know when you talk about um really, you have that loved one in the hospital, and they say to you, okay, they're ready to go home, and you kind of think, who determined this? So do you work with the discharge department, and if yes, how are the next decisions made if someone is to go into, let's say, go to High Point or DeGraff, or if they're to go home, or if not their home, to their home with their sister or their daughter or son.
Excellent question. In regards to discharge planners, the patient care management department is made up of RN patient care coordinators and social workers.
Ah,
So when you're saying, well, who decides where a patient goes? That decision is made by the multidisciplinary team, of which patient care management, meaning the RN patient care coordinators and social workers, are an intrinsic part. What happens is the provider, whether it's a physician or a physician assistant or the nurse practitioner, that is the person who will ultimately decide where that patient goes based on their medical surgical status, how they're doing, what they need. But here's the thing, they don't make that decision alone. They
okay.
need the input of physical therapy. They need the input of RN patient care management and social work in regards to, okay, their medical benefits and what the best discharge plan is for them. We are the subject matter experts in regards to discharge planning. That's what patient care management is. However, we do not work in silos. We need the collaboration of our multidisciplinary team, like physical therapy, like nursing, like nutrition, as well as consultants, specialty consultants. And at that point, all of us together will make a recommendation to the provider who ultimately has the marching orders and directs everyone. Okay, based on what everyone's saying, the patient's going to go home with home care. The patient's going to go to a post-acute care facility, whether it's a long-term acute care hospital or it's a skilled nursing facility for long-term placement or for subacute rehab. So while we play a very intrinsic part in discharge planning, the person who ultimately makes the decision is the provider.
Um, Now how about the only person you didn't mention in this is the family? Where does the family come in with the decision, or doesn't? Or I know the family has some. I'm assuming the family has some type of a role in the patient, or don't they have a role in this?
No, absolutely. And when I say patient, and that's just my what I usually do. When I say patient, I automatically mean patient and family because everyone has a support system. Everyone has their idea of family. So when I say patient, I totally mean patient family. So of course, we always include the next of kin, the emergency contact, healthcare provider, healthcare proxy, or um, power of attorney, but just the patient support system because you have to include them. The patient is not going to stay in the hospital, and we need to know what support they have in the community to make a determination what the best discharge plan is for them. So, for instance, if a patient only has a granddaughter who's still in high school,
Right.
okay, that's their family, but having them go home with home care may not be the best option when their acuity of illness or what they need is that 16-year-old is not going to be able to help them. So we definitely always bring the family involved, bring the family into it. And the family is a great resource, an awesome resource. And we
Yes.
need our families to let us know, hey, I know you think that patient can go home, but let me tell you why they can't. We work 24 hours. They can't cook their own meals. They live on a third-story walk up. So we need that vital information. We can't do a discharge plan without a family. Absolutely.
Yeah, thank you. And for our listeners, one very important thing I forgot to include, and Andrea, that's our guest for today from Kaleida, Andrea Wallace Stewart's title. You may think, how does she know all this? Because Andrea has a bachelor's in nursing, and she's a registered nurse, and a also has a degree or certificate. You tell me in care management coordination. So she is an expert in this area and has been trained in this area and working in this area with patients and family and where to place them for several years. So she's new to Kaleida, but not new in her knowledge and what she's been doing. Correct?
Yes, ma'am. I found my niche in care coordination and case management in 1996. So I've been doing it a while in very big hospital health systems, as well as on the insurance end. And I do have a certification in case management that I've held since 2006. I'm also a member of the American College of Healthcare Executives. And the great thing about case management is that you see the patient and the family from before they even get into the institution or the hospital or whatever healthcare setting that they need to get into, to them going to the community back home, whether it's home or a different type of home that they normally are used to. So it's very gratifying. It's very gratifying. You also include population health, which is part of our post-acute care strategy here at
And what
Kaleida
and,
Health.
and you know what? That's a word. Post-acute care. That is a hospital term. What does post-acute care mean? When you just said the word, but everyone may not understand
Yes,
what that
ma'am.
means. Yeah.
Yes, ma'am. So post-acute care basically means the care that's being arranged and coordinated for the patient to go back into the community. So it's after the patient has finished their hospital course, that's where post, meaning after, acute, meaning hospital, and care. So it's basically after the hospital care is completed. Now there's a different care that's needed to support this patient in the community.
hmm And Andrea, let me ask. So I don't want or I don't want our listeners to think that if their loved one does need to go into a long-term care facility for rehab, I don't want them to think that they necessarily um, stay there, and vice versa. If they come home and they realize that they um, are have some limitations, they may go back. So let's say, I'll just take it the first step, which is once you're in a facility, long-term care facility, can you go home, or is that your home for the rest of your life?
Oh, no, no, no. So thank you so much for that question. And that's a really good question because, I really think the general public needs education around this. And so I'm happy to provide it. So thank you for that question. So here's the thing. When patients and family come into the hospital, sometimes we have those instances where they get into the hospital and the patient and family together have decided, you know what, there's no way we can bring mom back home. She needs to go into a subacute rehab. Okay, what a subacute rehab is the patient's going to go into a skilled nursing facility for a very short time, usually 20 days, 20 days, somewhere around 20 days or more, to get rehabilitated and then be transitioned home, probably with home care, depending on what their needs are. Here's the thing: when you go to a subacute rehab, it's not for the long-term placement, not initially. Now, let's say a patient comes into the hospital, has surgery, they clearly need some subacute rehab to get rehabilitated before they go home. They get into the rehab, and then it's like maybe there's some medical or physical changes. And as a result, you know, we've tried to rehabilitate mom or dad. Seems that they're not going to be able to go home. So then the patient can be considered for long-term placement. But again, that's a total decision. That's a total different decision that has to be discussed with the patient's family. And again, the great thing about going into not a great thing about going into a subacute rehab, but the great thing about transitioning to different levels of care is that they have meetings. They have comprehensive care plan, comprehensive family planning meetings, so everyone can have this discussion to say, okay, this is what mom, dad is doing now. This is where we're trying to get them to go. Again, a care plan is a living, breathing thing. It evolves, and it's based on what our patient is doing, and that will determine where they go in regards to the support that's in the community. So to shorten it, just because you go into a subacute rehab does not mean that you're gonna, that's the place where you live. Absolutely not. And let's say you go home with home care, just the other side of the coin, like you were saying, you go home, you discharged home with home care, and you find out, wait a minute, we thought mom, dad, was able to do this, but clearly they can't. Here's the great thing. Here at Kaleida Health, we have the Great Lakes Integrated Network, where prior to the patient leaving to go home with home care, we connect them with our Great Lakes Integrated Network to make sure that they have services like that they're connected with community services to ensure that they are supported in the home care setting. So let's say they go home and they can't function. We connect them with VNA, our Visiting Nurse Association. They're one of our preferred providers for home care, and they're in our preferred provider network. And again, a patient is screened before they leave to make sure that they're going to be able to function at home. The home care agency will not accept the patient if their needs are greater than what the home care agency can provide. And at that point, again, a discussion is had to say, maybe they need to go into a facility just to get some rehabilitation to make sure that they're at their best level and can function home with home care.
Yeah, and then also sometimes it's a matter of maybe that when that person was discharged, let's say that person was what the person who was responsible for them at home, maybe they weren't working, maybe they had taken an extended vacation, maybe they had to return to college or to the military, and then they realized that that was a person who was helping. So again, it's a family decision, and that's where if there's no one there at the house to help like they were when they were first discharged, That's where again you have a family conversation. Now, do they have it with you, or do they have it um with someone from your team? Who do
They
they?
have they have those conversations with the RN patient care coordinator and or the social worker. And then, to be honest with you, what we're doing now with our restructuring of multidisciplinary rounds, again, that's where the whole team gets together to discuss each and every patient to make sure that their treatment plan and their discharge plan is individualized, fitting that patient and family. Because again, we are very patient centered here about at Kaleida. It's not just, oh, room 200, the hip replacement. No, it's patient Andrea Wallace Stewart and all the things that make Andrea unique and what that person's unique individual treatment and discharge plan is, including their resources.
Andrea, you have definitely have given us a true vocabulary test today, and that's
Oh,
why I'm going to ask you
I'm
if you
sorry.
could define. That's okay. No, no, no. That's why. I mean, I always stop everyone and all the guests. Treatment plan. Now, what is a treatment plan, and does the family have? What is a treatment plan? Who is part of a treatment plan? Because that's very important. Treatment
Absolutely.
plan. And if you could just
Absolutely.
talk a little bit about what is a treatment plan? Is there family involvement? Um, you know, uh, so if I'm taking a multiple choice test, check all that apply to a treatment plan. What would I
Okay.
check?
Okay. So anytime you go into the hospital and you have a diagnosis, we're treating Miss Smith for congestive heart failure. Okay, I'm just pulling that out of the air. When we're meeting for multidisciplinary rounds, excuse me, when we're meeting for multidisciplinary rounds, and that means the whole team is meeting, the provider is coming to us with a treatment plan. The treatment plan is, okay, Miss Smith has congestive heart failure, so her treatment plan is we're going there. It's like the recipe of how we're going to take care of the patient.
It's the
So
recipe. It's the
it's the
recipe.
recipe. It's the recipe that the chef, aka provider, is saying, well, we need to make sure these labs are okay. We need to make sure that this medication is doing its job. And the goals of care, meaning what we need to achieve to make Miss Smith better, is met. So we need to make sure that her labs are within these values. She's able to ambulate because she has to go home, and for 12 hours, she's going to be by herself. So is she able to wash herself, take care of herself, groom herself, cook her meals? Again, the treatment plan is the recipe for how we are going to take care of the patient.
And the family has an input in that as well.
The family has an input in everything,
Oh, great.
because again, we take what the family we take the information that the family provides us to help guide us with the recipe. But the thing about it is the family has no, if a patient has congestive heart failure, the family isn't going to say, okay, well, you're going to put them on those medications. No, that's the provider. Do you see what I'm
Yes.
saying? So
Yes.
it's
Yes.
really provider driven. It's really provider driven. Now, if the provider wants to put the patient on some IV antibiotic or IV infusion medication, well, we're going to take what the family has to say in account, because maybe there isn't family at home that can help do this. You understand what I'm saying?
Yes, absolutely. And I definitely have seen that have seen that happen. So when you talk so when the patient goes into, let's say, long-term care, let's say they've had a stroke. It wasn't a bad stroke, but they just needed to regain their strength because they hadn't gotten up and walked in a while. But is there someone within your department who goes, because what we want to prevent the patient coming back into the hospital. That's all part of why we have this care management team. Listeners, we want to prevent your loved one from coming back into the hospital. So after so many weeks, is there someone from your team who then follows up with that long-term care facility or the VNA to see how progress is going?
Yes, and that's a very good point. Reducing readmissions or preventing readmissions is always best practice and optimal outcomes for the patient, for the family, for all involved. Having patients come in and out of the hospital is never, a best practice for their care. And as you know, Kaleida Health is patient centered. What happens
Yes.
is, again, when a patient is discharged and they have visiting nurse association, again, they're one of our preferred providers. They always follow up with us in regards to how the patient is doing. Okay, if a patient is going into a subacute rehab, because subacute rehab is very different than long-term placement. The patient's going from the hospital to long-term care. The skilled nursing facility is their new home. Okay,
Yes.
if the patient's going for subacute rehab, they're just going for a certain amount of time, and then hopefully they will be transitioned home with home care. Again, if they're using our preferred provider facilities, our post-acute care network, then yes, we have continuity of care because our providers are have privileges at those facilities, and we have a better eye in regards to, okay, Miss Smith who broke her hip, or Mr. Smith who had the stroke, okay,
All right.
he's under Dr. Shields, who's a provider there. We can definitely have follow up.
Thank you. You know what? We only have about 2 more minutes left in the program, or maybe about 3 more minutes. And my question is because what you do to me is fascinating, and that's how we started this conversation for the interview. So what steps have you taken towards your success? I see you as a success. Not only are you a success, you bring success to the hospital. So, what are some of your successes, steps that you've taken that if someone is listening in high school, post high school, in the middle, what steps should they take to follow in your footsteps?
Okay, well, thank you for that. In regards to the successes that I have assisted in achieving here at Kaleida Health, again, length of stay is a really important issue because the longer a patient stays in the hospital, um, it's not the most optimum outcome. We want patients home sooner because we have found, and as best practice, that the sooner the patient goes home, again, they convalesce and they get better quicker. Some of the things that I have assisted with is, again, restructuring our multidisciplinary rounds to make sure that they are efficient and effective. As making sure that our RN patient care coordinators are asking the right questions, and
Yes.
that they are operating at their top of their license for our patients and families. And as a result, at Buffalo General, we have seen a decrease in length of stay from December 2024 to March right now. We are also predicting discharges earlier. So now our RN patient care coordinators and social work teams are predicting, well, this patient is going to be going home tomorrow, or will be leaving our hospital. So we want to make sure that everything is together to make that transition as smooth as possible. For anyone that wants to follow in my footsteps, first thing I would say is make sure that you are serving in healthcare for the right reasons. This is not great. This is not Grey's Anatomy. This is, no,
ER.
ER. No, that's fiction. That's drama.
All
People don't
right.
have time for all of those relationships. Yeah, we're busy working and taking care of the patient. So that's number one. Make sure you're doing it for the right reasons. The right reasons is you want to help people.
And
you don't find sacrifice as an issue. You because you're going to have to sacrifice your time, your effort, your energy for the greater good.
And you know what,
And
Andrea? And you know what, Andrea? On that note, I'm going to say we're going to have to end, but I want to let listeners understand what you just said. Working in healthcare, it's about sacrificing your time and your energy for the greater good. I like that quote. Can you write that down and I can use that again?
I will send that to you in an email.
Thank you. And so our guest for this morning has been Andrea Wallace Stewart, a nurse at Kaleida Health, and she is a vice president of care management and post-acute transitions. And this program definitely involves the family, making sure your loved one is as safe and healthy once they leave the hospital. And now on to part two. And welcome to the second half of the Great Lakes Health Radio program. I'm your host, Francesca Messiah from Kaleida Health, Manager, Workforce Development. And I just want to thank you for staying on since the first, listening and not changing that dial. Or if you're just joining us, welcome. And again, I appreciate listeners. I appreciate you listening. I appreciate when I see you in the community asking, letting me know you've, heard a show. But I also want to say to you, listeners, when I see you, if there's a show that you would either like repeated or a topic we haven't covered, please let me know. Kaleida Health, we have over 13,000 employees, and I know we can cover the topic you're interested in hearing. All right. Well, moving on. So the second part of our program, we'll be speaking with Nicole Caver, who is a regional perinatal data specialist. Good morning, Nicole. How are you?
Hi, good morning. I'm good. Thank you.
Oh, thank you for getting up early this morning to join us. And our topic for today is the regional perinatal data specialists who, and they are part of Oshai Children's Hospital. I don't think I mentioned that before, but they're part of Oshai Children's Hospital. And so, Nicole, we are just going to get right into the topic. And you are a data specialist. How did you get into this field?
So I got into this field, specifically public health, after I graduated with my undergrad degree in biology. I think my senior year, I took a class in epidemiology and I really fell in love with the field. So then I went on to pursue my master's in public health from George Washington University. And ever since then, I've been really interested and kind of enamored in data analytics and data science. And also, while pursuing my graduate degree, I also really felt compelled to focus on maternal and child health, considering the complex issues that our state and the country faces when it comes to maternal and child health.
That's true. That's so very true. Um, so what is the Regional Perinatal Center and how long has a perinatal data center been around and been collecting data?
Sure. So the Regional Perinatal Center, or the RPC, is a designation given by the state in its effort to regionalize perinatal healthcare across the state. And basically, it provides the highest level of care to birthing people and offers a level 4 NICU. And basically, that means that we are able to provide highly specialized care to some of the most sickest neonates or infants, and also some mothers or birthing parents with very complex pregnancy issues or complications after pregnancy.
Hmm. So does that mean that that's where if someone had a premature baby, that's where they would probably you would probably be collecting data
Yes,
on the baby?
Yeah, so we would hope that all of our affiliate hospitals, if there is a birthing parent in the community who gives birth at one of our affiliate hospitals, and our affiliate hospitals are distributed across all the 8 counties in Western New York, except for 2, because they are now maternity deserts due to their delivery services closing. But if a baby who was less than 35 weeks or 32 weeks were born in the community, we would hope that they would come to our hospital, considering we can take care of neonates as young as 23 weeks and above.
Okay. What was the number you said? 35 weeks?
Yes. So we normally say that 35 weeks and above is generally, quote unquote, low risk. And those would be the pregnancies or deliveries that our level ones would be most comfortable handling. And they do an exceptional job of making sure that those babies are safe. But sometimes when complications arrive, or if they are less than 35 weeks, then they'll have to be taken to a hospital with a higher level of care. And that's kind of where perinatal regionalization comes in. We want to make sure that people can go to the places that they need to go and have the services tended to them that are best suited for their needs.
And now you say 35 weeks. How many months is like 30? Around how many months are we speaking of?
I believe that's close to 7.5, close to,
Okay.
yeah, around that. Because 40 weeks is term. Anything 37 and above is considered term. And then 35 would be like late preterm.
Okay. So so besides collecting the data, do you collaborate? Because I believe there was a program that your department, Regional Perinatal Center, collaborated with Buffalo Pre and Perinatal Services, right? Wasn't there a program a couple of months ago?
Yes, we held our annual conference, the Perinatal Updates Conference, if that's what you're talking about,
Yes, the
and
perinatal, what was it?
the Perinatal Updates Conference.
Yes, yes, yes. And what was that about?
So it was basically an event to try to engage our community members, and as well as our hospital members, people who work in clinical settings, to discuss current best practices for maternal and neonatal care, and also find ways that we can better support each other in these organizations, and making sure that our patients are satisfied, making sure that our staff feels comfortable and up to date in what they're doing, and to know that as the RPC, we are trying to support all efforts to advance and improve care within the Western New York region.
And RPC is Regional.
Perinatal Center.
Okay, okay. I just want to make sure that our listeners understood. So, what were some of the outcomes? What were some of the lessons learned, or things who people might have been charged with as a result of the conference?
Yeah, so one of our speakers was Dr. Robert Haas. He is a physician out in Olean General Hospital, and he works at a level 1 hospital. And he shared a couple of examples of how, we may just be a level 1 hospital, but we are mighty in the care that we provide to our patients. And he described to us some out of the box ways that he was able to increase medication adherence for an Amish family who they experienced some difficulties during their pregnancy, and making sure that they abided by their medication regimen was a way that the baby was healthy and that the birthing parent was healthy as well. We heard from Dr. Michelle Loria. She talked about some of the life or the like later in life complications of pregnancy complications, and how they can manifest later in life. And we also heard from people who talked about ways that we can better support mothers dealing with substance use disorder, and how we can reframe our language so that we can provide more compassionate care. And also from Sally Dreslin, who works a lot in rural health, and she provided us with some maternal rural health statistics that were, I feel like we're a little bit of a missing link to our region. I feel like people underestimate how rural our region is. And when you get outside of Buffalo, the populations are pretty small and pretty spread out. And rural health is of great importance when we're talking about the Western New York region.
Yes, and rural health is also one of those, national topics you hear as well because they don't have the same facilities. But thank you for that for the update. So what's the process of once the data is collected, how decisions are formed?
Sure. So we take the information that the data provides to us, and we also look at what are, like I said, current best practices. And those usually come from agencies like, or organizations like the American College of Obstetrician Gynecologists. We take advice from the from AAP, American Association of Pediatrics, to help inform the care that we provide. So some of the outcomes that have come from that, and also some of the decisions that are made are also due to state projects that they have going on. For example, the Birth Equity Project that has now transitioned into the Birth Equity and NTSV project, which stands for nulliparous term singleton vertex. And in theory, these patients who present with those features should have an uncomplicated vaginal delivery. And when we see high rates of NTSV, sometimes it can be unclear.
Uh-oh. Acronym, what does that mean?
Nulliparous term singleton and vertex.
Okay,
Those
thank
are
you.
all descriptors of how the baby is presenting when it's ready to be delivered. And it's a combination of things that can indicate that the delivery, like in theory, should be low risk, but we know that isn't always the case. And looking at the number of, like looking at the rate of those deliveries kind of points out, well, are we doing the best thing all the time? Like, were these types of deliveries indicated? And looking at the rate can kind of tell us, well, is there any way that we can bring this down? Because if in theory they were able to have a vaginal delivery, well, why didn't they? And if it was a true medically indicated reason, is that something that we can work towards?
That sounds complicated.
It is, and there's a lot more to it. I know that they are ongoing with this initiative and that it's pretty new, but it's a hot topic in our communities. And yeah, it's something that a lot of people are looking into. It's not like a definitive like cause of bad outcomes or anything like that. But if we see areas that can be improved, it doesn't hurt to try to make an improvement and see if it makes a difference in the quality of care that people receive and their time in the hospitals.
Well, yeah, and you know what, and I know you keep mentioning in our community, this is a national topic. I mean, this is very much a hot topic when you talk about vaginal births versus C-section births, and that's a whole conversation that's also. So I'm glad that Kaleida remains on the cutting edge when it comes to topics, such as at our children's hospital, such as delivery and just the importance. And I'm glad that you're there helping, and you're part of the team. So then, do you work with all moms, or do you work or more with mothers who might be at high risk? And what does high risk mean?
So high risk can mean a couple of things. So usually it's any birthing person that's over the age of 35, has a BMI greater than 40, has any chronic illness or disease like diabetes, hypertension that maybe came about during pregnancy, or any other serious chronic disease. And the data that is discussed regionally with our affiliates, it encompasses all moms who have delivered at any of the birthing facilities. However, the data that I mostly deal with comes from the NICU at Oshai Children's Hospital.
And the NICU, for those of us listeners who aren't familiar with it.
It is a neonatal intensive care unit.
Okay, so it's a intensive care unit for babies, newborns.
Yes.
So then do you work only with high risk, or when someone is deemed to be high risk, or do you work with all moms? Does the data work with all moms?
So my data primarily focuses on the babies. So I enter information into the statewide perinatal data system, and it keeps track or keeps record of all NICU admissions across the state. And I do the data for Oshai Children's Hospital. That data then is used in in various ways. And as I mentioned before, we have meetings with our affiliate hospitals. So when they send babies to us, likely they do go to the neonatal intensive care unit, and then we can report back to them on, you know, what they were diagnosed with, how long did they stay with us, if they received follow-up from a community physician, like once they got back home, things like that.
Mm-hmm. So how long has the New York State, how long has this system been in place in New York State? And what is it called? The New York State.
The statewide perinatal data system.
And how long has it been in existence?
I am not quite sure, but I will say they've been collecting this data for at least 25 years.
Oh, okay. All right. No, that's really interesting. What do you think would happen? This is just your opinion, or opinions you've heard from others in your department or in your circles. What would they say if this data was not collected?
I believe we would have a very misunderstood outlook on what is happening in our region, specifically being unique to New York State. A lot of things that come out of the state mostly target the New York City region or maybe the Albany region. And I feel like sometimes the Buffalo, Western New York region gets left out or a little bit overlooked or just lumped in with the rest of the state. And Buffalo, just like Rochester, just like Syracuse, we have unique needs to our area. And without the information that is provided from systems like the statewide perinatal data system, we'd have a very big misunderstanding of what's happening in these areas. I feel like this data really does characterize some of the issues that are seen across our counties. For example, the issues that are seen in Cattaraugus and Chautauqua counties are not the same issues that are seen in, say, Niagara and Orleans counties. So it really does provide a very good perspective on the current landscape of our Western New York region.
Wow. Now that was a lot that you just said. Um, when when do they when does the data process begin? And I'm going to take a guess. Does it like begin at the time when the mother begins delivering, or does it start before that? Like like when does that chart begin to populate?
I would say it really depends on exactly you're looking for, because depending on what you're looking for, it can start all the way back to the first prenatal visit, or it can just start on admission to labor and delivery, or it can start with um, let's say their readmission from home. Let's say there was a perfectly fine, healthy baby, but somehow they got sick and had to be admitted into the NICU sometime later after their birth. So it would really depend on what exactly you're looking for. I'll say for the system that I work in, it all starts with their NICU admission. So that's the data that I'm evaluating and entering into our system.
Mm-hmm. And I'm listening, but I'm thinking that the data is collected once the child is in the birthing process. and not thinking that they could go home and return to the hospital with complications. I'm thinking everything is within, within, the delivery. That covers quite a bit of things.
Yes. And I will say, since there is a lot of data, there is also a lot of really cool innovation that is coming out of the data that is collected, not just in our region, but across the state. And it allows for a unique perspective and a unique approach to solving issues that we all face. So it is a lot, but it comes at a good price. You know, we do get beneficial information out of it.
Well, without giving away any medical secrets, what are some of the can are you able to discuss like a few things that people are doing across the state that works to improve the health of the child, of the baby?
Sure. So, like I mentioned before, the Birth Equity Project was put in place, I believe, sometime in 2022, 2023. And it was to better understand how people were feeling in the hospital, like how represented they felt in being able to care for the baby, how involved did they feel the care team, like how did the care team make them feel? Did they feel involved? Did they feel like they didn't have much input in how they were caring for their baby? It really has shown different ways that hospitals can improve the overall approach to healthcare delivery they can provide to people. And there we just had a coaching call, I believe this Wednesday, and the way that hospitals have approached, documentation and having parent partners and having culturally competent care, or yes, culturally competent care has made a difference and people's reported experience while they were in the hospitals and have led to an increase in positive reports about that.
Mm-hmm.
So, and like I said, each hospital is unique. I believe one of the hospitals that were on the call that were sharing insights, they were in Rochester. And it
Mm-hmm.
was just really amazing to hear the engagement that they had from the parent side and the healthcare staff side to increase the reported positive experiences that they had.
And I know you've mentioned birth equity a couple of times, and I know that a few years ago, I remember when and it may still be, but I remember, it was part of DEI, and I try and say in every show, at Kaleida, we still have our diversity, equity, and inclusion department that includes, several different areas. But is the birth equity, and that when you talk about cultural competency, those types of things, do you work along with the Kaleida diversity, equity, and inclusion department?
Yes, we've collaborated with them as well. They've provided insight on making sure that we're meeting the project measures,
Mhm.
and making sure that when it comes to things like signage or trying to deliver messages to our patients in the hospital, that it is culturally sensitive and is, you know, acceptable for all crowds.
Hmm. And I know that regardless of language, we are at Kaleida, all of our departments, we're able to communicate with our patients at either at all of our sites across the entire system in multiple languages. So I wanted to add that. Nicole, I know our interview is winding down. So what would you like to add that we've not discussed?
I would like to share that, in our region, the RPC here, we are working to make sure that our mothers and our birthing parents and our babies are receiving high quality care, and that as we go on to further promote perinatal regionalization across Western New York, that we are able to communicate very effectively with our affiliate hospitals, making sure that they feel supported with everything and trying to be transparent with our affiliates and also with the patients that come to us so that they can understand the reasonings that they have to come here and feel supported in all aspects through their care, whether they remain in the community or they come to us in Buffalo.
Well, on that, I just want to say, my area is workforce development. Are there any, not to say are there any openings, but if somebody is interested in getting into this field, what are some of the steps that they should take, if they're in school, going to school, thinking about returning to school? What are some of the steps that would prepare them to do the kinds of work that you do?
I would definitely say having an interest in maternal and child health, familiarizing yourself with hospitals in your area and what kind of birthing services that they offer. That'll indicate the type of patients that they see, and to have a good grasp on the area or the landscape that these hospitals and facilities are in, and also being aware of community resources that exist to support the ongoing efforts at the hospital. Because even if there aren't positions available in the clinical setting, they are available in the community setting. So building and discovering the network that exists will really help.
Yeah, and again, something else that you just said, that it's just, again, that's why we're doing this interview. When you said to investigate what kinds of birthing services they offer. What are like the top three things you work at? A level one hospital, Oshai Children's Hospital, Kaleida. What are some of the things you would just recommend that people look out for when they're thinking about where to deliver that cute little bundle of joy?
I feel like all in any of the hospitals in Western New York, they'd be in good hands. Um, I would just consider just if you start out at any hospital that's not our hospital, just consider that if pregnancy complications arise and you do receive a referral to us, and if you have to come to us, just know that you'll be in good hands.
Yes, and that's true. Regardless of where you have your little bundle of joy, if there are any complications, hopefully they'll never will be. But if they do come out, if something does happen, that know that they're in great hands here at Oshai Children's Hospital. And on that note, Nicole, I thank you so much for being our guest. Our guest this morning has been Nicole Caver, Regional Perinatal Data Specialist, part of Oshai Children's Hospital. Nicole, thank you so much.
Thank you.
Oh, you're welcome. And listeners, I just want to say thank you for listening to the Great Lakes Health Radio program. And next week, you'll hear from my esteemed colleague, Cindy Bass from Erie County Medical Center. And if you're looking for employment, job, change career, please visit our Kaleida Health website. And when you get to when you type in Kaleida Health, KALEIDAHEALTH, with that little box, click, type in careers. And I believe last time I looked, we had over 500 openings, some clinical, some non-clinical. Some of the positions you just need a high school degree or a GED, and others you need an MD degree or a RN degree. So please visit our Kaleida Health website for careers. And on that note, my name is Francesca Messiah, Manager, Workforce Development, Kaleida Health. Look forward to seeing you in 2 weeks. Bye-bye.